Thank you very much. I want to give special thanks to Dr. P. Rasad Aziz for arranging this wonderful course and also for giving me the opportunity to talk. I'm glad and I'm humbled to present, the endovascular management of aneurysms in front of my teachers and seniors like Dr. Lutfi, Dr. Fawzia Sajjad, and Dr. Anwar Chaudhary, with whom I had the pleasure of working with very recently, a few months ago. So I'm very happy for the participants that they will be getting excellent guidance and supervision from the senior faculty members. So without any wastage of time, we'll just talk about the endovascular treatment of these intracranial aneurysms. We'll just go over some guidelines, some treatment options, and how to pick and choose these treatment modalities as we see these patients. So essentially, the goal of an aneurysm treatment, as you all know, is to prevent hemorrhage or re-hemorrhage from an aneurysm. Especially in Pakistan, we see most of the aneurysms are ruptured aneurysms. But the eventual goal is to prevent, obviously, initial hemorrhage if they are found incidentally, or when they present after ruptures to prevent re-hemorrhage from them. And the ideal treatment, it needs to be safe, it needs to be effective, and it needs to be durable so that you don't have to keep coming back and keep treating the patient again and again and expose them to more risks of complications and anesthesia. So essentially, the treatment plan for each patient needs to be customized. You have to take the patient and the aneurysm specifics into consideration, and that will help you in treatment planning. And as you all know, once you look at all the specifics, the two options are either open microsurgery and endovascular therapy. In this presentation, obviously, we're not going to talk about open microsurgery, but we'll focus all our attention towards endovascular treatment of aneurysms. So essentially, for treatment of intracranial aneurysms, we have to see what's in our toolbox as vascular and endovascular surgeons. Obviously, we have clipping and bypasses, but from an endovascular standpoint, you can treat aneurysms by simple coiling or stent-assisted coiling, or balloon-assisted coiling in cases of wide neck aneurysms. More recently, we have been using the Webb device, which is an intrasaccular device that can be used for both wide and narrow neck aneurysms. And the flow diversion like Pipeline by Medtronic and Surpass that is made by Stryker are excellent addition to this toolbox. And then some other devices, which are neck bridging devices that have come into the market more recently. This device, which is called the Contour, which is something that you place right at the neck, and that prevents hemorrhage from the aneurysm, and you don't have to really fill the aneurysm with coils or anything like that. So what are the advantages of endovascular surgery for aneurysms? It's a shorter and a simpler procedure. Well, it's simple as compared to open surgery, but still needs a lot of training, and you have to think about a lot of things. You cannot it's not as simple as just taking a picture and trying to put a catheter in. You have to think about a lot of things, otherwise you can really hurt the patient. It is less invasive, but you have to understand that just because the procedure can be done through a small access from the femoral artery or the radial artery, it does not mean that bad things cannot happen. We have all seen or heard about cases where the coils have ruptured the aneurysm or the pipeline gets twisted. So there's a lot of technical nuances and challenges for these cases. And because there's no craniotomy involved, patients usually have a shorter recovery and they usually are able to go home or get discharged sooner. However, there are disadvantages for endovascular therapy. There's a higher rate of, there could be a higher rate of residual or recurrent aneurysms. However, that number is slowly declining as the technology gets better. You have to do some angiographic follow-up. So even if you coil an aneurysm or do a flow diversion, it still needs angiographic follow-up. And as compared to clipping, which has been around for almost 100 years, we have a shorter experience of about 30 years or so, 30 to 40 years of coiling experience. But since most of the aneurysms, at least in the Western world, are being treated by endovascular means, the number of patients in that cohort is getting much larger. So, the data which we will see in the next few years will have a huge number of patients in those trials. So hopefully we should have much more robust data to support and give us the real story about the endovascular surgery moving forward. So as we said, there are a few ways of treating these aneurysms, but largely you can divide them into these three options: coiling, flow diversion, and intrasaccular flow disruption. And over time, over the last 30, 40 years, there has been significant advancements in the technology. So as you all know, as we started with this typewriter, and then eventually we had these old DOS or Mac computers, and now we have these big, very fancy computers. Similarly, we started with these GDC coils in the early 90s, which then we had these evolution of stents like Enterprise or Atlas stents, and now we have intrasaccular devices like Webb right now. So technology has really improved over the last 30, 40 years. So we've got some videos here. This is a video of simple coiling. Again, there's no such thing as simple coiling because, as I said, coiling can also be very challenging. But this is just a very quick video cartoon demonstration where simple coiling essentially involves that you get the catheter safely into the aneurysm, and then once it's in the aneurysm, then you can deploy these coils slowly and try to fill the aneurysm as much as possible. And you have to keep repeating the angiogram when you're doing this procedure to make sure that you fill them enough that there's no blood flow into the aneurysm. And then some of these coils, like microvention coils, these coils actually swell up after you deploy them. And then once they're deployed, when they come in contact with the blood, a thrombus forms, and then there's some endothelialization that happens at the neck of the aneurysm, which is made up of smooth muscle cells and endothelium. And then once that happens, the aneurysm is considered treated. But whenever you're treating these aneurysms with coiling, you have to look at several aneurysm characteristics. You have to look at the size of the aneurysm. You have to look at the neck size. There is a wide or narrow neck. There's something called dome to neck ratio, where you want to make sure that the dome of the aneurysm is at least twice as big as the neck. And if it is, then you can most of the time can coil the aneurysm without needing a stent or a balloon. And then you have to also see to make sure that there are no branches that are coming from the neck of the aneurysm, because if you don't take that into consideration, you can easily occlude the side branch and then cause a stroke. So in those cases, sometimes you will need a balloon or a stent. So here's a picture of a balloon-assisted coiling. So sometimes if it's a wide neck aneurysm and you don't wish to put a stent, sometimes if patients have a big hemorrhage or they cannot be on antiplatelets, then you can deploy a stent like this. You can deploy a balloon across the neck of the aneurysm that provides a support, and then you can deploy the coils behind it. Or sometimes you can protect the side branches of the aneurysm with the balloon by inflating it and then coiling behind the balloon. Sometimes if you need a stent, this is how this procedure is done. These videos are sponsored by Microvention, so they have a device called the Elvis. But there are several stents like this. There's an Elvis, there's Atlas, there's Enterprise stents, and they have all different properties. But they're not flow diverting stents. They're open cell stents, which basically means that they have just a mesh of metal, which is about 6 or 7% surface coverage, so not enough to treat the aneurysm by itself. But so what you do is, as you can see, this is a wide neck aneurysm. So you deploy the stent across the neck of the aneurysm like that. And once it's deployed, the other catheter is actually pinned behind the stent. It's trapped. We call it the jailing technique. So you have jailed the microcatheter, which is going to coil. And then once that is done, now you can deploy the coils, and the coils will not fall into the parent artery. And once that is done, you can remove the other catheter, the stent stays, and the aneurysm is essentially secured. More recently now, obviously we have been using flow diversion. And the concept of flow diversion is that when you disrupt the flow of the blood into the aneurysm, the thrombosis of the aneurysm will occur and the aneurysm will shrink in size and eventually disappear. The blood vessel heals across the stent, across the flow diverting stent, and then essentially you can get excellent results from that. And the good thing is you don't have to access the aneurysm itself with a catheter, which sometimes is probably the riskiest part of the procedure. So in that procedure, how does flow diversion work? Essentially, when you have blood that enters the aneurysm, you deploy the stent across the neck of the aneurysm, and then immediately as soon as you deploy the device, the blood slows down. The blood flow to the aneurysm slows down eventually, and the aneurysm starts to thrombose and shrink, and endothelialization happens. Endothelium forms across the neck, and the vessel basically reconstructs across the flow diversion pipeline device. So again, this is another video. So there are different devices. There's a pipeline, there's spread, there's surpass. So again, flow diversion is great for parophthalmic aneurysm. So here you can see this aneurysm in the parophthalmic region. It's wide neck, so you can stent assist coil it. But nowadays, most people will choose to do a flow diversion. And this is pretty much just like we see other stent deployment. However, there are some technical nuances because you have to be careful as to how the device is deployed. But once you deploy it, as you can see, slowly the flow of the blood into the aneurysm slows down, and the aneurysm will shrink over time, and then the vessel will heal over itself. And essentially, in a few months or a year or so, the vessel will actually look almost completely normal on follow-up. So here's an example of a giant parophthalmic aneurysm. You know, in the older days, in the 90s, people would try to either occlude the artery completely, parenvesical occlusion, or do something more dramatic, and the patient can have a stroke. But now, for these cases, you can deploy a flow diverting device. As you can see here, you can see a picture of the flow diverting device during the angiogram right here. And once this is placed across the neck of the aneurysm in the internal carotid artery, the aneurysm over time shrinks, as you can see here, and in this segment in E, and then eventually the vessel reconstructs it to where it completely looks normal after a few months. So again, this whole procedure, if everything goes okay, it takes about 30 to 45 minutes. And once you deploy the stent, the aneurysm will eventually shrink. Again, this does not happen in all the cases. Sometimes the aneurysms might not completely go away, so you might have to put a few coils in it or have to deploy another stent or a flow diverting device within a previous device. But that happens, infrequently. It's not a very common occurrence. The next thing we want to talk about is the endovascular, the intrasaccular devices. These are called it's called the Webb device. More recently, I think there's another device that is being trialed right now. It's called the Seal It device that Dr. Osama Zaidat and Amir Badruddin have designed, and they're trialing that device right now. It's a similar concept where in wide neck basilar, in MCA bifurcation and basilar bifurcation, you can deploy this device very quickly within less than 5 minutes. And the device essentially fills the aneurysm and stops the blood flow into the aneurysm and then eventually occludes it. It's technically sometimes can be challenging because you have to know how to size the device, because if it's too big, it can rupture the aneurysm. If it's too small, it won't occlude the aneurysm. So it takes a lot of training and experience to properly size the device for the aneurysm to get optimal results. So just a quick video of the embolization system. So this device is actually very soft when you take it out, outside the body. If you deploy it, it's actually a very, very soft device. It's very compressible, as you can see. That's what the video is trying to show you. And it has these nitinol wires. So this is how you measure that. You measure the height of the aneurysm and you measure the width. And you increase, on your measurements, you increase the width and you lessen the height by a little bit. And once you put the microcatheter in, you deploy the device. It fills the aneurysm. And then that's showing you how you detach it. And once you detach it, it's pretty much done. Obviously, this is simple representation. It's not as simple as that. Sometimes it can be quite challenging, but if it goes well, it can really shorten the duration of the procedure and fix the aneurysm within 5-10 minutes. So, much faster than any craniotomy procedure can, treat the aneurysm. So this is an example of a basilar aneurysm. As you can see, a web device was placed, and once it's placed, the aneurysm is completely gone. The PC and the SCs are completely open, and obviously nowadays nobody tries to clip these basilar tip aneurysms because there's so many perforators involved, and takes a long time to do these cases. But if with a web or even a stent-assisted coiling, this procedure can be done in less than an hour, and the patients can pretty much go home if they are unruptured pretty much the next day. And then this, as I talked about, this is a device that is out in Europe. It's being trialed in the United States right now. It's a neck bridging device. This is even more simpler than the web that I just showed you. And so the idea is you do your measurements as shown in the picture above, and then you essentially deploy this device at the neck. So that's why it's called a neck bridging device. So you just put it across the neck of the aneurysm, and then it does not allow the blood to get into the aneurysm, and then quickly takes care of the aneurysm itself. My disclaimer is I've not had the opportunity to use this device, but hopefully soon, inshallah, we'll have it in our center, and I can share my experience hopefully at a later point in time. So in summary, for ruptured aneurysms, the coiling or endovascular treatment has become the treatment of choice. And the patients who could be treated by either method, like which is surgery versus endovascular, multiple trials have now shown that at 1 year, they tend to do better if they are treated with coiling. And coiling is safer than clipping for poor grade patients. However, there are some poor grade patients which have a huge hematoma or midline shift or mass effect. They definitely need to be treated surgically. However, retreatment because of coil compaction or residual or recurrent aneurysm is slightly more common with coiling procedures than clipping. And in unruptured aneurysm cases, the risk of endovascular treatment is a little lower than surgical clipping, especially in patients who are more than 50 years old, and especially of the aneurysms which are either large or complex or involve the posterior circulation. Several series have shown that the endovascular coiling is significantly safer than clipping in these unruptured aneurysms. However, there is no prospective randomized trial that compares the two modalities. So when coiling initially started back in 1995, coiling was only reserved for aneurysms that were not amenable to clipping. So coiling was considered for patients who could not get technically the good treatment or the gold standard treatment, which was clipping. However, over 20 years now, coiling and clipping are considered complementary techniques. And you have to, as I mentioned before, you have to look at the aneurysm specifics and the patient specifics to decide what's the best treatment. And therefore now we're in this era where you have to individualize the treatment decision based on patient and aneurysm characteristics, and as well as, more importantly, the expertise of the local physician treating. So for somebody who has very good skills or experience with clipping aneurysms, but has minimal experience with coiling, obviously in those hands, clipping, let's say a simple MC bifurcation aneurysm would be much better than trying to coil this because of limited experience. But on the flip side, if the surgeon is not experienced enough or has not done a lot of clippings, then coiling in those cases by an experienced radiologist or a dual trained surgeon will be a better option. So those things have to be individualized on a center by center and patient by patient cases. And with that, I will end my presentation. And if there's any questions, I'll be happy to answer those questions. Thank you very much.